You're very savvy from a business perspective, so not only practicing, but you understand the business of healthcare. I mean, very clear from our discussion so far. Other physicians, I'm sure colleagues of yours would, probably rather just see patients and not be involved in all this macro MIPS and, all this detail. But yet, their behavior impacts your practice, and as you said, their behavior may impact attributable patients and so forth and so on. So I'm kind of curious for our audience, including some of our students who study health administration and maybe implementing these programs, maybe non-practitioners, but in charge of kind of some of the people that you mentioned might be hired. Thoughts on how you kind of approach those who really just want to see patients. They want to practice medicine, yet it's important that their decisions along with their colleagues in whatever group or organization, match up to these incentives so that the overall entity is not severely penalized. And I'm curious as to, sort of how you approach that with your colleagues.
Well, again, this is all going into effect. So this is all prospective thinking, but, I'm in a group of eight physicians. Partners or not, we have two associates. Well, we have actually one associate and 7 partners. Soon that'll change. We'll have 8 partners. But in essence, you don't want to have an outlier. You don't want to be the outlier. So prospectively, we need to wrap our heads around what are going to be the outcomes measures and how much control do we have on influencing those. Cost is, of course, something we have probably the most internal control on. How much. We do a lot of procedures within our cath lab, and it's a unique situation in Texas and in the country. In Texas, per se, we own a cath lab, and we do a lot of outpatient procedures in there. We have control over which suppliers provide us with various catheters, whether they're balloon catheters, stent catheters, atherectomy catheters, and so on. So if we can keep our costs down on the supply side of things, well, the end of the day, the procedural cost should be controlled. But as far as clinical outcomes, if we can really wrap our heads around what the Medicare measurements are going to be, to develop some kind of an internal measurement, so we have a dashboard by which we can operate by, and just to check it periodically, once a month or once a quarter, just to make sure that you're not veering off into the land of the outliers, because MIPS does give the physicians in a group the option to either be graded as individuals or as a group. So I think there's a little more stability in the group measurement, but if you have 3 or 4 guys that are in a group that are practicing way outside the realm of whatever your specialty is, and outcomes are turning out adversely, you may want to opt out for an individual.
Yeah. As you mentioned, this is about to go into effect, but this is a broader piece of health reform more generally. Maybe the question is, how interested are your colleagues? Again, those who really are most interested in patient. I mean, how worried, how interested, how much around the exam room, the hospital, the office? Is this a matter of conversation?
Yeah, it's tough to gauge. I think that we're so busy seeing patients, and hundreds of times a week we have encounters with patients. And it's been that way for 10 years plus for a lot of us, and 20 and 30 for some other guys. That how you practice, it just doesn't change overnight. And if Medicare rolls out a new piece of legislation as far as how we're going to be reimbursed, it's not as if we're going to change the way we practice. The way we practice is based on, first of all, everybody in my group is board certified in either general cardiology or general cardiology and interventional cardiology. So we have kept up our certifications, and we stay current. In that regard, a lot of the core for becoming and maintaining your board certifications is based on practice guidelines. And we would hope that Centers for Medicare looks at those practice guidelines, and if we stick to those and hopefully they provide us with the outcomes that they're looking for, then I think everything should be fine. That's the thing. Unfortunately, when administrators, legislators, and physicians speak, even though we may be trying to talk about the same common goal, the language we use is very different. So it's hard for a physician to read the MACRA legislation or hear about it from a non-physician and understand if they're really in the game or not. That's the toughest thing. So I think a lot of liaison work needs to be done between the practicing in the trenches physicians and the people who are rolling out MACRA and trying to describe what they're looking for as far as outcomes. That's the tough part.